Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. Umbilical cord prolapse is when the umbilical cord is delivering ahead of the baby. So this may be a cord that has come all the way through the vagina and is seen or felt between the mother's legs. This could be one that's not visible yet, but can be palpated in the vagina. Or it could also be the cord is in front of the presenting part, but it's not yet come through the vagina. Any of these situations is an emergency because this is going to put pressure on the cord that is going to decrease oxygenated blood flow to the baby, which can cause hypoxia or even death. Risk factors for an umbilical cord prolapse. If the baby is not engaged in the pelvis when the water breaks. If the baby is still floating when the water breaks, the water can bring the cord with it down and in front of the presenting part. This can also happen with an abnormal presentation. If you have a transverse or breech baby, it's possible that we don't get good enough engagement. So again, then the water can bring the cord down. Hydramnios, or also called polyhydramnios, is when we have a lot of amniotic fluid. And so when that happens, then we have more fluid that's coming out when the water breaks, which can also bring the cord down. Things we might see with a cord prolapse. A big sign would be fetal heart rate decelerations, especially immediately after the water breaks. So this isn't the only time that we can see a cord prolapse, but it is the primary time. So if the water breaks and immediately afterward we're seeing decelerations in the heart rate, then we should investigate further. We could see the umbilical cord protruding from the vagina, or we could palpate the cord on exam. And so again, this frequently happens when the water breaks. So this is the time that it's very important to assess the fetal status whenever the water breaks. This is what we're looking at. We're looking at an umbilical cord that is down in front of the baby's presenting part. So in this case, the head. The head is going to put a lot of pressure on that cord. So when we think about the other things we might see, the fetal heart rate changes. So let's look at what that might look like. So after the water breaks, if we're seeing variable decelerations, or if we're seeing prolonged decelerations, this is a sign. So whenever there's pressure on the cord, we can see an abrupt drop in the heart rate, which is what causes your variable deceleration. And so if we see an abrupt drop in the heart rate, then this could be cord compression from a cord prolapse. Also, if we have prolonged decelerations, or even a fetal bradycardia is going to be if that presenting part comes down and stays on it for longer. So longer for prolonged, or if it just stays, that pressure stays, then we can see the bradycardia. So any of these fetal heart tracings could be an indicator of a cord prolapse. So our goal for a baby that has a cord prolapse is oxygenation. And so when we think about what we need to do to keep that baby oxygenating, we need to get some help. We need to get mom in a position to take as much pressure off the cord as possible. So the primary position for this is the knee-chest position. This means the knees are on the bed, the chest is on the bed, and her bottom is up in the air. And that's going to allow gravity to rock the baby back and take some of the pressure off the cord. We can also do the modified Sims position, where she is on an exaggerated side-lying position, and then we can also do a Trendelenburg with the bed in this position, and both of these will also let gravity help move the baby back. The other thing to do is going to be to elevate the presenting part. So typically the person who finds the cord will be the person that's elevating the presenting part, but it could be, if it was a provider, that you switch to a nurse to do this. Elevating the presenting part involves putting 2 fingers in the vagina and putting pressure on the head or whichever part is presenting and trying to lift it off of the cord as much as possible. And so if this is what happens, then the person who is elevating the presenting part needs to keep their hand in there until we deliver the baby via C-section. So that person will stay on the bed and roll back to the operating room with their fingers holding the presenting part off the cord as best as they're able to. Other things to consider. So we can also think about oxygenating mom. We can put oxygen on mom. Truly, we need to still think about if we oxygenate mom well, if we're not getting that oxygenated blood through the cord, that's not going to fix our situation. So it's something to consider, but it's not going to be the thing that fixes everything. If the cord is protruding from the vagina, we can wrap it in a warm, sterile, saline-soaked towel until we can go to the operating room. This is not high priority either unless you are finding a cord prolapse outside of the hospital setting, but you do not want to put the cord back into the vagina. The more that you manipulate the cord, the more that you can cause the cord to have its own vasospasms that affect blood flow, in addition to the pressure that's happening on the presenting part. And then we need to deliver. This requires an immediate cesarean delivery. And so it's an urgent, emergent situation. So an umbilical cord prolapse is when the cord presents before delivery of the baby. We could see it between the mother's legs, in the vagina, or in front of the presenting part on exam. We can see variable or prolonged decelerations or even a fetal bradycardia on our tracing. And this frequently occurs when the water breaks. This isn't the only time a cord can prolapse, but this is the primary time. So priority number one is going to be oxygenation for the baby. So we can call for help, get in a good position to try to let gravity keep the baby off the cord, and then we need to elevate the presenting part off of the cord. Do not put the cord back into the vagina, and we need to do an emergency cesarean delivery. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.